We've got some business to take care of. Um, We'll go ahead and get started with the House Insurance Committee. I want to thank everyone for being here at 8 o'clock on a Monday morning. Um, I know I hear the boos. That's okay. That's okay. Um, I'm going to ask Representative Lumsden if he would open us with a word of prayer.
Would you bow with me for a moment, please? Almighty, most holy God, we thank you for this day. We thank you for loving us, for watching over us and caring for us and providing us with so many blessings. We thank you for the opportunity that you've given to each of us here to serve you. We just ask, Lord, for your wisdom and for your guidance and direction as we do the business of the of this state, and we just ask that you would give us insight so that we can make the best decisions that honor you and that help the people of Georgia. We thank you for this day. Amen.
Thank you, sir. All right, Senate Bill 8. Senator Renee Unterman. Oh. Glasses. Okay. We'll see. We're having a little private conversation up here. There's a lot of that goes on in committee meetings. But before we get started, or before the senator gets started, I'm going to ask the committee to indulge me as I take a moment to make some introductory remarks about Senate Bill 8, the substitute, it's LC 372407S. The Surprise Billing and Consumer Protection Act is a result of a great deal of work on the part of both the House Insurance Committee and also the Senate Health and Human Services Committee. I want to thank all members who have worked in good faith to tackle this crisis. In particular, I want to thank Chairman Unterman from the State Senate for leading in this charge. Senate Bill 8 is a good measure, one which I hope I will see signed into law. But I'll be honest, and I'll say that I'm disappointed that I have been able to only to get this far. We should have gone a lot further. Surprise billing is a problem across our nation. It's a result of a complex web of insurance policies, contracts, regulations far removed from the control of the consumer. There's ample data to support this observation, as you all know. The Kaiser Family Foundation, the New England Journal of Medicine, the Journal of the American Medical Association are among the credible sources that have published reports on this topic. They show that, you need to listen to this, they show that 22% of the time patients who went to a hospital covered by their plan still receive a bill from an out-of-network doctor. These reports also found that 7 out of 10 individuals with unaffordable out-of-network medical bills did not know the health care provider was out-of-network at the time that they received their service. Surprise billing is completely avoidable if insurers, hospitals, and doctors will put the patient's well-being first, both their physical and their financial well-being. You need to remember that the cost of health care is the #1 reason that people declare bankruptcy. Also, based on a recent study, 1 out of every 3 of your constituents will get a surprise bill in the next 2 years. And as such, I will continue to work on this issue. I will stand up for Georgia's consumers who've fallen victim to surprise billing when they are least able to take care of themselves. I want to give you a couple examples. I've talked to my pastor, and he said some of these surprise bills come out 12 to 14 months after the procedure's done. And also, there's a little note attached to that that says, pay within 10 days or it will turn you over to a collection agency. And when you see some of these surprise bills that may go from a few $100s, the largest one I've seen so far has been $15,000, a surprise bill. most people cannot afford that. Now, I'm excluding air ambulances altogether. Air ambulances are a different animal. They're regulated by the FAA. We have no control over them until that issue gets resolved. But I've seen some of those bills, surprise bills, in excess of $100,000 that the patient is requested to pay. After we adjourn this session, I encourage and I expect the stakeholders in this debate, our insurance providers, our hospitals, and particularly our doctors, will make good on their claims of putting the patient first. Senate Bill 8 substitute is a step in the right direction, but it's only the first step. We've got a long ways to go and a lot of work left to do. So, Senator, I'm going to turn it over to you, and I want to commend you on your efforts in stopping these surprise bills. You held numerous hearings last year. You introduced legislation last session, I think. I'll turn the Senate bill over to you.
Thank you very much. I appreciate it, Mr. Chairman, and I especially appreciate meeting with you. I feel like I've spent as much time in your office as I know I have in my own office. And it's been a long journey, but I think like you, I believe there is a long journey to continue. This folder right here is Senate Bill 8 and the number of revisions and reiterations that we've had of Senate Bill 8. Senate Bill 8 did pass the Senate, I believe, I can't remember, but I believe it passed unanimously. But the version that is before you takes a different method than what the original Senate Bill 8 was. The original bill was a compilation of hearings that we heard, not just here at the Capitol, but in other areas of the state. And there are many people I would like to thank. The Georgia State Retirees Association, they have been some of my biggest supporters in trying to resolve this issue and to have stamina in trying to resolve it. They've just been great champions on this particular issue. And the reason they are is because they live on a limited budget. And a lot of them retire before they're on Medicare, and so they are fearful of surprise billing, as are a lot of people. And as you talked about, unfortunately, it has become common practice when I go around the state talking about this. Just about everyone I know has had a surprise bill at one time or another, whether it's from the anesthesiologist, the radiologist, the pathologist, or most commonly the emergency room. And that's really what brought me to the table. Was I live in one of the biggest counties in Georgia, Gwinnett County, and the school system is 190,000 kids approximately, so you can imagine how many teachers we have. And unfortunately, those teachers were on the state health benefit plan with Blue Cross Blue Shield. And also, unfortunately, the main provider, the Gwinnett Hospital System, was out of network with their emergency rooms. So I said, how could the largest employees in the county be going to a hospital when you know that every teacher and every family of those teachers that goes to the emergency room is out of network? And one of the reasons is because those emergency docs knew that they could balance bill them because they probably have two incomes, and they would be willing to pay the $300 or $400 or $500 and get it out of the way when they take Johnny to the emergency room with his broken arm and get it x-rayed. So I persevered, and I appreciate you working with me. The two versions are completely different. My version went to the issue of surprise billing by sending it to mediation, completely taking the patient out of it so that you had the two industries working it out together, where it was the medical industry, which are the providers and the insurance companies, and the patient was completely taken out. And out of all the hearings we had, the number one issue is dollars. Now, you can talk about patients all you want and caring about patients, whether it's the doctors or it's the insurance companies. It's all about the dollar. And that's what these negotiations have been about, is reimbursement cost. And in the original Senate Bill 8, it took that reimbursement cost to a database that was called the Fair Health Database. And also with the current Medicare reimbursement rate and the Medicaid reimbursement rate, and it came up with a number combining those three numbers, and that's what the reimbursement rate. In states that have used mediation and have the hammer over these two industries, what we've found is there's very few cases that actually go to them, because they know there's a resolution process, and number one, they don't want to go through with it because they know it costs money to go through with it, or they know that their reimbursement rate is not much more or much less than what their contract reimbursement rate is. So when I met with the chairman, he decided to take out that mediation and come up with more of the transparency part of the bill. And that's essentially what we're down to, is letting the consumer, as a consumer, beware. Consumer, be knowledgeable about what can happen to you. Even though you may have insurance, you may be out of network, and that out of network may be frequent. And he took the transparency part of it and made that the basis of the bill. The only thing that is similar to the original Senate Bill 8 is the emergency provision on line 238, where it talks about out-of-network physician and the emergency situation. So, Mr. Chairman, I guess I will let you answer questions. I did receive from the Hospital Association yesterday some concerns they have, because this transparency really shifts a lot of their workload onto the hospital system, and letting the hospital system notify the consumer of what cause of action is fixing to happen. Unfortunately, when you go to the emergency room, I know I had my gallbladder out, and I had it out at St. Joseph 2 years ago. And, you know, I scheduled my gallbladder out at 6 o'clock in the morning, and you show up at 5 o'clock in the morning, and you walk in, and the intake person starts getting out your insurance cards. And, you know, the problem is, if you find out you're out of network with your anesthesiologist at 5 o'clock in the morning, are you going to turn around and leave and say, oh, God, my gallbladder's killing me, I can't eat anymore? You can tell I like to eat. So the question is, are you going to turn around and if your anesthesiologist is not in network, are you going to turn around and leave the hospital and reschedule and try to find an anesthesiologist that is in network? That's the main dilemma, and hopefully with the transparency that you're setting up, you're going to know beforehand that you can call the hospital and find out if your anesthesiologist is in network and out of network. So with that, I could talk forever. I'm sure you don't want me to, since it's 8 o'clock in the morning, and I'll answer questions that I can. If not, I'll refer to the chairman.
Okay. I don't see any lights lit up. Okay, 19.
Good morning.
Morning.
Listen, I appreciate what you and our chairman are trying to do here. You know, I treat patients all the time, and they do come first. But I have some problem with the premise of this, and I hope and I wish we would have a very thorough study committee before we had acted on this, because I'll tell you, you know, I've been treating patients for 40 years, and I've seen all kind of things come down the pike. We have alternative benefits now, where the codes are changed that we send into insurance companies and coded down to a lesser treatment. We've got anesthesiologists, friends of mine, that are working for less than $22 a unit. A unit is 15 minutes. So for $88, They're paid to provide anesthesia in the hospital. I can't get a plumber to come to my house for that much. You know, I think sometimes it's more of a question of, are the docs charging too much, or the insurance companies paying too little? And also, you know, I've come to find out that Georgia's the second highest state with narrow networks in the nation, and this is coming from the Anesthesiology College. So, although there's some good things in the bill, I still see some things that really trouble me, making us or having us being in charge of knowing what insurance companies that patient's insurance covers. I mean, what other other physicians or dentists that their insurance company covers. It seems much more reasonable to me for the patient to be calling their carrier, their insurance company, to get a list of the physicians, dentists, or whoever. And so that way it's an up-to-date current list. Because even though you renew this every once a year, every 12 months, these contracts are happening every day, every month. They're not all clicking on the same day. So I'm making more of a statement than a question, and I apologize. Again, though, I do appreciate what you're doing. I know what you're trying to do to help patients, and they do need the help. Thank you.
Thank you. We have studied it in the Senate. We've spent about the last 18 months coming up with Senate Bill 8, and I don't disagree with you, but the problem is when you keel over right here and you have a heart attack, you're either going to be taken to Grady or probably Piedmont.
Right.
And you go into the emergency room, you may be in network, you may be out of network. You don't have the opportunity to check and see. There's not a list available to you. You just know you're having chest pain,
Right.
and you're either going to get stents, or you got indigestion, or you're going to have open heart surgery.
Right.
And when you get into the open heart surgery, it can be devastating. Yes, your heart may be cured, but 6 weeks later, when you go home, you may be having another heart attack when you see the bill, when your anesthesiologist or your thoracic surgeon was not in network.
Right.
So it's a major problem. Lots of other states have come up with solutions. Some good states have been New York, Texas, California, Florida. Other states have remedied their problem, and I feel like we have the institutional knowledge to be able to remedy our problem too, and that patients deserve it. And whether this is the best bill going forward or this is just the first step, I agree with the chairman. This is the first step, and we're going to continue to work on it.
Thank you.
In regard to that, I think I've made this statement before. I've told MAG on numerous occasions that this problem exists because, I hate to use this term, but that's what the term I've used with them. You've got some rogue doctors out there who decide they're not going to get in network, so they can send any bill that they want to send. And I can give you an example. There was a gentleman in Rome that had a colonoscopy. The total bill for the anesthesiologist was $2,500 for an outpatient procedure. Insurance paid $3,000, and he got a bill in the mail for $2,200. And I've mentioned to MAG on numerous occasions that most of the issues don't apply to 95 to 98% of the doctors. It's that small group out there that's generating this conversation. I told MAG, like I said, on numerous occasions, if we didn't have this small group that's generating this issue, we wouldn't even be having this conversation right now. And we shouldn't be having this conversation right now, but we are. Okay, number 10.
Thank you, Mr. Chairman. To my friend, my senator, I'm looking at line 239, and it's the section about an out-of-network physician shall not balance bill. I notice we define surprise billing, and perhaps Chairman Smith could answer too. I'm not sure which one would be better to answer, but we define surprise bill. Does balance bill need to be defined, or is that defined elsewhere in the code, or is that generally understood?
The
what that
general
means?
definition of a balance bill is the difference between what insurance pays and what the bill charge is.
Okay.
If you have a procedure done and your insurance you know, the bill is, like in that particular case with the anesthesiologist, if the total bill is $2,500, the insurance paid $3, well, the balance part or the surprise part of that is the difference between what the insurance pays and what the
Right.
network charges.
And I guess I would kind of add to my political statement, I would add to what my friend Mr. Hawkins said, that you know, we are kind of setting the pricing here, and it's may or may not cover the cost of what the doctor needs. It seems like it's setting us up like creating a similar problem like we have with Medicaid, where doctors are required to perform services and not getting their costs covered. And I agree. There are a lot of good things in this bill. This is an incredibly serious issue, and I hope we do continue to work and find that right solutions. Thank you.
Okay, 17.
Thank you, Mr. Chairman. I join everyone else in just telling the Senate sponsor, we appreciate all your hard work on this. This is an issue, along with the chairman, that I think everybody here at the table agrees that we need to try to address. And obviously, moving this bill along is part of our only chance of doing so. But I think everybody knows I have a lot of concerns about what's going on with our rural hospitals in the state. And so as we move this process along, I just hope that we will keep in mind that in a rural area, or really any hospital setting, emergency services, a large percentage of the people that come in their back doors are the uninsured population, indigent care, and so forth. So we've always had to subsidize that portion of our care in our hospital settings. And in rural areas, we've had to basically resort to just using contract physician groups because you don't have the local doctors there to staff these emergency rooms, which every community deserves an emergency room, in my opinion, at least somewhere within 30 miles or so. But I just hope we'll keep in mind that we're always subsidizing this, and my fear is if we go in there and we mess with these fee schedules even more, which I hope we can fix this, but we have to make sure that as we do that we're not actually going to make these hospitals have to continue to subsidize this level of care even more. So that's just one thing I'll point out. I appreciate everybody's work on this, and I hope as we move it along that we'll keep all these things in mind. I just wish really that we could get back to the way it used to be when I was started out in the group business, which I hardly do it anymore. And we would have, it was just understood that if it was an emergency situation, that claim was going to be covered. It didn't matter if you were on vacation in another state, that if you were in an emergency and you went to the hospital, that you didn't have to worry about out-of-network. We were going to cover that, or the insurance company, as it was in-network. And that's the way it should be. So if we could, I agree with what you said. It's all about the dollar, and we need to get back to taking care of the patient.
Thank you, sir. I had about a 30-minute conversation this morning, and probably well over half of the conversation had to deal with issues that you just referred to. You have a lot of communities that don't have physicians. You have a lot of communities that don't have the population to justify having a physician because they can't pay off the student debt in some communities. So there are a lot of issues in health care that we've got to address. And when you have, I'm sitting close to a guy on the House floor that's had three surprise bills in 18 months. And some more that had some pretty significant surprise bills. It's an issue that has to be addressed, but what Representative Shaw was talking about is a major problem for rural Georgia. I mean, it is, people who live here in Atlanta have no clue about the seriousness of that condition in rural Georgia because they don't have dentists, they don't have physical therapists, they don't have doctors, they don't have a hospital. And, if you get south of the fall line and you have a major accident, you're in trouble. Southwest Georgia, population there in some of those counties less than it was in 1940. So there's a lot of issues in health care that we have got to address. Number 16.
Thank you, Mr. Chairman, and to the author of the bill. I thank both of you all for bringing us to this very important issue. But, Mr. Chairman, you got to know that everywhere I went this weekend, the doctors were giving me the blues about this.
Oh, I understand.
About this particular bill. Now, my question is, when we send this back over to you, what are you going to do with it?
Well, we're going to go to conference committee, and I've been working, like I said, I've been in the chairman's office. Marty gets tired of me. I go in there and take my shoes off now because my feet hurt so bad. He likes my smelly feet, I think. But I plan on continue working with him. And, you know, the docs want to go back to the Fair Health. And the reason they want to go back to the Fair Health is because they know they get a better reimbursement. Sometimes in the Fair Health, which is the New York database, their reimbursement rate is more than their contracted rate. And our greatest fear of that is, well, if their contracted rate is less, are they going to take more complaints to mediation? And yes, they probably would, because they want to get paid more, and they see that as a mechanism to get paid more. But yeah, the doctors are complaining. You should read some of the letters I've gotten. They're not very nice letters. They're not looking to solve the problem. They're looking to complain about the problem, because I can't see them coming to the table with he and I and trying to resolve it. They haven't been knocking down our doors trying to resolve it. They just complain about it. So I understand the letters. The letters you get, I'm getting the same letters. But let me tell you who you're not getting the letters from: the consumer. If you look at the consumer groups and anywhere you go, I did a meeting. I had about 300 people there, and I had 12 people come up to me. I didn't know them from Adam's House Cat. They had read about this bill in the paper, and 12 people came up to me and said, "Renee, whatever you do, keep working on what you're working on, because I've gotten a surprise bill and it's not fair. I pay my high insurance premiums. I pay my deductible. I scrape to pay my prescription cost. And then all of a sudden, I got to come up with more money after I get my procedure done."
Well, Mr. Chairman and Madam Chairman, my concern is that not only we do something, but whatever we do, it is the right solution for the issue that we face. And this healthcare issue operates in the bigger environment, and there are a lot of things going on in healthcare at this particular time. So nobody's going to be in conference but the two of you. So we're looking for something that's going to work.
Could I just add one thing? This is private insurance. This has nothing to do with the Affordable Care Act, and I know you know that. This has nothing to do with the changes that are going on with Medicaid in Washington. This problem existed before the Affordable Care Act. This problem is going to be here after the Affordable Care Act, and it's up to the states, because every state is completely different. When I started working on this, I took the New York model and tried to fit it into the Georgia code, and you know, that's what other states have done. Florida, California, like I said, Texas. I have that synopsis of what every state has done in this folder.
Okay. Number 11.
Thank you, Mr. Chairman. And you can't have a conversation with either Senator Unterman or Representative Smith and not know the passion that you guys have on this issue and desire to protect the consumer. I too share that desire. As I think about this issue, my goal has been always to both protect the consumer and not put either the insurance companies or the hospitals in a bad financial position. And I realize that there's always tension when you've got those three things in the same sphere. As we look through the I guess the end of section 2 here, the part that you said, I guess that's lines 237 and following. Line 243. So it says that the reimbursement in an emergency situation would be the greatest of the median network rate, the in-network rate basically. Number 3 being the Medicare rate, but number 2, I'd like to drill down on that a little bit. The rate of the health care plan and its standard formula for out-of-network reimbursement. is that public information? Is that something that is known?
Well, I can tell you, when I've had a complaint before and I go to the Department of Insurance, and I'm sure I'm over the Health Committee, but the chairman of the Insurance Committee, whenever I've had a complaint before, Department of Insurance can get those numbers from the contracts. They are private information and they are proprietary information, but every time I've gone there, they can tell you what is the usual and customary cost. I'm sure the chairman could talk more about this because he deals with it more than I do, but that is my understanding. And in my original Senate Bill 8, that was going to be the holder of the database was going to be the Department of Information in accumulating those usual and customary costs.
Okay, because
In regard to that, the insurance department had even agreed to collect all that data and to utilize that data as far as paying what rates would be versus the Fair Health, and the opponents to this bill did not like that either.
okay, so I'm not in insurance, and I am also not a physician. I didn't even say at Holiday Inn Express. So by definition, so if they're in the network, by definition, if they're out of the network, that means they've not agreed to the negotiated rate.
Right.
So
And they sometimes purposely do that, just like
Sure.
I was talking about Gwinnett Medical Center with Blue Cross Blue Shield, and that when you were talking about the rural hospitals, this is an urban hospital, but these are huge emergency room groups. They're not 4 or 5 docs. They can be 25 emergency docs that work as a corporation. So they can purposely make the decision, well, we don't like the contracted rate, so we're going to go out of network. And that's the problem.
And the tension I feel, and I'm certain you feel it too, is you don't want to punish the good actors who are a little bit more expensive than the network rate. But at the same time, they're not trying to gouge the consumer. And so that's the tension I feel is how do we, if a physician services are a little bit more expensive than the negotiated rate, but they're not gouging the consumer, yet this would say, no, you will accept one of these rates. And so
Right.
that's where the tension I feel.
Well, I think it would be their decision, maybe I should go in network. Maybe I shouldn't stay out of network. I
Okay.
think that's what you're trying to get them to go to, is to be in network. And that's what takes up the issue of the narrow networks that they were talking about. And we actually had a narrow network bill. I think it was 2 years ago or a year ago, I can't remember.
We had House Bill 71 that required any doctor that had privileges at the hospital to have or be in network.
Right,
Because what you've got, you got 4 basic groups of doctors that have exclusive privileges at the hospital. They're the only ones there. Primarily your radiologists, the ones that Senator alluded to. But they have a monopoly there.
right.
They're the only group there that does that particular thing. OBGYNs, you may have several groups in there. But for those 4 groups, you've got exclusive privileges. You're the only player in town. So, and in most cases, they're the ones who are not getting in network. So House Bill 71 said if you have exclusive privileges at a hospital, you had to be in the same networks a hospital was, which to me sounds fair. If the hospital agrees to the network, why shouldn't you? But it's still alive and well, but it's sitting on the sideline right now. Okay, number 3.
Thank you, Mr. Chairman. I'm torn about this, and Senator for bringing this. I'm torn because I've had a surprise bill myself, having headaches. The doctor sent me to the hospital to get some CAT scans and got all the bills. Everything was paid, and then all of a
Did
sudden,
they find anything?
No, sir. I'm completely sane. I think it was just stress.
Okay.
So.
Well, you'll have them on March 30 too then.
Yes, sir. But and then you got a bill a couple weeks later from the radiologist that read everything. So, but I'm torn on this for a couple of reasons. I've heard a couple of comments today that it seems like it's all about the money, and I'm torn on that because I know a lot of doctors, they take the Hippocratic Oath to pledge to put the patients first and to do no harm. And I feel like the reason why the insurance companies have adjusted their networks and doctors are choosing not to be in network today is because we're already regulating to them and forcing doctors to lose money through Medicaid and Medicare. And so the reason why they have this whole situation to begin with the surprise billing or the balance billing, whatever we want to call it, is because they're trying to make up money that they're losing on one end. And it's because of government regulation, not despite government regulation. So I have a fear there because what we're doing in this bill is we're going to set some rates without even knowing what those rates are. I don't know what those rates are right now. I'm going to be asked to vote on a measure, and I don't know if the doctors are going to be able to keep their practices open with the rates. In rural health care has been brought up, and that's another concern of mine, is the access to care in rural Georgia. I'm in middle Georgia. We're pretty good, but you go a little further south of Warner Robins, and it starts to get pretty severe. And if doctors start being forced to lose money again, why are they going to continue to practice in the rural areas? Why are they not going to move to the bigger areas where they can get more clientele and make it up through volume? So that's one question, is the access to rural health care. I fear that this, as it is right now, Mr. Chairman, and you know I've had conversations with you on this, and I want to do something, but I have that fear. I've also heard it mentioned that we haven't had any other solutions provided. And, you know, I've gotten a lot of phone calls, especially this last weekend, and even leading up to the House bill that we had. A lot of conversations, emails, friends of mine that are doctors in my community. And ironically, when they were talking to me earlier in the session about the House bill, they were telling me to support Senate Bill 8 as the Senate was passing it, your original bill that passed the Senate, that it was a solution that they could deal with. So they have presented solutions. I believe one of the doctors even told me that there's another Senate Bill 77 out there now that is another solution that they're in favor of. So there have been alternative solutions. My fear with this is that we're stepping into a situation going to regulate reimbursements to a point that it's going to drive access to health care down in the rural, especially in rural areas. And I just fear, because I know the intention is to help solve a problem that exists, but I fear that we're going to have some unintended consequences that could be devastating. So,
Could I
yes,
answer?
yes, ma'am.
Well, first of all, let me tell you, I'm very familiar with rural. Even though I live in Gwinnett County, I can tell you I was in Folkestone, Georgia, 3 times when that hospital was closing. That's on the Okefenokee Swamp. I've been to almost every hospital that has closed in the last couple of years, and I spend more time in what John Wilkerson calls the hinterlands than I do in Gwinnett County, and my car's got the miles on it to show it, because I do try and visit all of these hospitals, and I think the Hospital Association. So I do feel real comfortable with what I know about rural health care, and I also fund the budget that subsidizes all those areas and the doctors. If you look at primary care, internal medicine, and OB/GYN services, that's the part of the budget that I help fund. So I think we have stepped up to the plate. The doctors are in panic mode. They're in panic mode in D.C. They're in panic mode here in the state of Georgia. They don't want to see changes. When you say they did come up with alternatives, that's not true. I came up with that alternative. Did they like that alternative? No. But do they like my alternative better than his alternative? Yes. And that's why they chose to go with Senate Bill 8. And that's why they came up with that. But they didn't come up with that alternative. don't go down that rabbit trail, because I can tell you they didn't go down it. They haven't offered alternatives, and I can tell you by the letters that I've gotten and being called everything in the book, you can see that they are in defensive mode. They're trying to divide y'all. And my commitment to y'all is that we will go to conference committee. We will continue to work on this. Richard has been, the chairman has been amenable to working with me. And we'll continue to work in the next 2 weeks trying to get some answers and listening to y'all and seeing what y'all have to say to incorporate into a final conference committee. I would like to see this bill move on, to give that opportunity to get to conference committee. Then when we get something at another stack of papers like this, you don't like it, then vote no. But I'm asking you to allow us as two chairmen that have worked so diligently to let us move on and try and go to conference committee and try and work it out.
Just whatever rabbit trail it went down, but all I know is that
We have
This-
rabbit
this-
trails
this-
in
sure.
Gwinnett County.
the Senate bill, as it passed the Senate, was something that my doctors were telling me that they would support.
Right.
And I fear if we amend this as it is,
Mhm.
I want to do something to help the situation.
Right.
And if we move forward with this, my fear is that it might get stalled out and we do nothing. And so that's just my concern, Mr. Chairman, honest
Well,
concern.
if you vote this down, you're going to stall out and do nothing. That's why I'm asking to try and move it on, and let's see if we can go to conference committee and work it out.
Now, this bill has to pass today in order to get something started, otherwise it will stall.
Right.
Okay, we've got several more questions, but our time is running out because we've got another bill that we need to hear. Senate Bill 50, we got about 3 more minutes on this one, so I'm on number 1.
Thank you, Mr. Chair. Madam Chair, I have a question. In the spirit of protecting consumers in Section 2, lines 59 through 61 is where we start to define health centers, and that includes the medically underserved, and specifically migratory workers, the homeless, residents of public housing, which I'm happy that they're included, and a little confused because generally based on income, those people might be Medicaid recipients. And so how do we actually protect the medically underserved with this piece of legislation if, as you stated, this is mostly about private insurance?
Medicaid and Medicare, you cannot balance bill.
Okay.
And that's just a definition.
Old age has its advantages in some areas.
Thank you.
18.
Thank you, Mr. Chairman, and Madam Chairman, thank you for bringing the bill here. I'm trying to make this quick. The Chairman's putting time limit on us. 2 places in the legislation, I think on page 90, line 96 and line 108, I see the mention of these ambulatory surgical centers that are mentioned in certain areas here. But then when you go back and look at under the definitions and where some of the requirements are for what's going on, let's see if I can flip back. I don't see anything mentioned on line 35, I believe it is, where there's some definitions that it appears to me they probably should have been mentioned there. Line 41, I don't see anything in that section about healthcare services. Line 35 is a healthcare provider or provider definitions. Is that assumed to include these ambulatory surgical centers? Also in line 41 following, where we got healthcare services, I see nothing else mentioned about the ambulatory surgical centers. And on line 149 and following, they're not mentioned. So why are we mentioning them in a couple of areas when we're not in others? Can I get any help on that?
I'll let the chairman answer that, but I picked up on that too, and I think the Hospital Association, that's just, needs to be an inclusion, in my opinion. I did pick up on it too.
That we ought to have those in there in these
We'll
other areas?
probably address that in conference. If it
Yes.
gets-
Could I be on that committee, Mr. Chairman? I just wanted to put that. Never mind. I won't put you on the spot.
You- I don't know, we gotta get there first.
All right, so y'all are aware of that.
Yes, I
Yes.
picked up on it.
All right, thank you very much.
Okay, 23.
Thank you, Mr. Chairman. Madam Chairlady, thank you for bringing this as a major issue, including in my area. I guess this might be more of a question in regard to, this is a continuation of the process, but I'm looking at the version that passed the Senate.
Yes.
And this is in regards to lines 262 to 297. This is in regard to a dispute resolution process established with the commissioner. I guess that's just a matter of ongoing negotiations. Is that correct? I'm just conscious of time here.
That's, that was a part put in there for mediation.
Yes.
One of the issues you have there is that if you look at the state of Texas, from what I understand, they have currently a little over 500 mediations waiting to be processed. So it can get to be a burden, and with the mediation process and the fair health based on the physical note, it would cost the state of Georgia $5 million to get this set up. That's the physical note that we received the other day.
Thank you.
24.
Thank you, Mr. Chairman. I'll be brief. Several of the issues I have been addressed, like the ambulatory, but one of the, I guess the overriding issue here is what to do for the citizens of Georgia. Healthcare is not a free market. We might want to think it is and apply it that way, but it is not. And it's unfortunate, we might say, because we have so much government involvement, but doing nothing helps no one. We need to get everybody to the players, and I don't have a crystal ball, but I'll tell you, this is not the end of it. This is just opening the door. We've got to go forward and do something. Remember what we represent, and that's the approximately 54,000 people in our district. And I, like both chairmen, have had numerous complaints from constituents about this issue, and it's not going away until we step up and do something. Thank you.
Thank you, ma'am. We also have an amendment to this bill. It impacts primarily Aflac, which is not in this kind of situation. It excludes them. I need a motion to add amendment 0364 to this. Okay, got it moved. Second, all in favor say aye. All right. All opposed, like sign. Yes, sir.
Well, there's other companies other than Aflac that sell
Oh,
that
yeah, I
type of
understand, but it's
insurance.
this-
Yeah, I
this
just
type
wanna
of
make-
group.
Yeah, that type of group. Okay,
Right,
I
this
just wanna
type of
make sure
group,
I have a company that, I know of a company
Right.
that sells something similar.
Right, I understand. All right, so that's been amended and added to this piece of legislation. Well, it's showtime now. I need a motion for Senate Bill 8, substitute Senate Bill 8 as amended. Need a second? All right, guys, one second, all in favor say aye. All opposed, like sign. Very good, thank you, ma'am.
Thank you.
You need to go by and see Mr. Meadows.
Yes, I
and-
will.
and
Thank
fi-
you. I
and fill out
appreciate it.
that form. Thank you,
Thank you.
ma'am. All righty. Senate Bill 50. No. Okay. No.
There's one no.
He didn't say it. Okay. Senate, we got just a few minutes before rules starts. Matter of fact, 11. We've got Senate Bill 50 as it relates to concierge doctors. If you haven't heard of those, you will. Could I ask for quiet in the audience, please? Okay.
What do you say these are, Mr. Chairman?
Concierge doctors.
Just hire your own doctor.
Well, you pay a fee for membership to see that doctor, and it's not insurance. That's basically what the bill does.
Why don't we do that? For everything, we wouldn't have to worry about this insurance thing.
Well,
I don't think everybody can afford a concierge doctor. Go ahead.
Mr. Chairman, thank you very much for hearing the bill, members of the committee. I look forward to sharing this bill after hearing that debate. I think it's very appropriate that we should discuss it. As you all know, we're the ones that pass laws that regulate insurance, and a lot of times, government's the problem and forces insurers to make adjustments to make money, and that's what we just had a debate about. So this bill does the opposite. It allows us to reinvigorate the doctor-patient relationship and put that singular transactional model back into healthcare, where it's between a doctor and a patient. And it allows insurance to focus on what insurance is supposed to do, which is to protect our consumers when something unexpected or catastrophic occurs. But so let me go through some of my remarks and what's being passed out to you. We had 2 doctors that wanted to testify, but they couldn't make it down here, so they wrote their testimony, and it's being passed out to you. But simply put, direct primary care is concierge medicine for the everyman. It puts patients back in the driver's seat. Empowering the relationship between doctors and patients is the key to achieving superior health care outcomes, lower costs, and an enhanced patient experience. Direct primary care fosters this by focusing on 5 key tenets. Service. The hallmark of direct primary care is adequate time spent between patient and physician, creating an enduring doctor-patient relationship. As you know, doctors are having to do so much paperwork as a result of insurance, and insurance provides a fee-for-service model that forces doctors to have to see multiple patients in a day to make money. And this would allow them to spend more time with patients and be able to give them greater service. This expands patient choice as they choose their own personal physician and are reactive partners in their health care. This eliminates the fee-for-service, at least in primary care. These incentives distort health care, fee-for-service does, because it rewards volume over value. And this undermines the trust that supports the patient-provider relationships and rewards expensive and inappropriate testing and referral treatment. How it works. For those who need a quick explanation, it works like a healthcare gym membership. In exchange for a membership fee, and the industry average is about anywhere from $25 to $85, patients have access to primary health care. They can even schedule same-day appointments and longer office visits with their doctors as needed. A major reason why monthly fees are affordable for the masses is because many DPC practices follow a micro-practice philosophy in which most resources focus on patient care. By opting out of insurance contracts and accompanied claims personnel, a DPC practice can sustain itself while devoting just 1/3 of revenues toward overhead. So let me just get to what this bill does. These arrangements can already occur. Many of your constituents may already be in an arrangement where you have concierge medicine, but they are not in our code. And so for the purpose of the bill is, in my opinion, to legitimize the practice and to clarify its purpose. And it's 3 things this bill allows. It allows people to have choice regarding how they pay for their health care. It allows healthy people to save money on insurance. They can control their maintenance costs and purchase a high deductible plan for a catastrophe, which is really what insurance is all about. And it saves primary care doctors the red tape of having to deal with insurance companies if they choose not to. If you look at the legislation, it basically articulates that this construct is not to be treated as insurance, and it's an arm's length transaction. A doctor and a patient come together. Patient pays the monthly fee that's been agreed to in lieu of the services that are offered. It's a monthly payment, so if either party is unhappy with the relationship, they can cancel. But again, you can see the details in the bill. The whole purpose of it is to reinvigorate that doctor-patient relationship and increase better health outcomes at lower costs. So I look forward to your questions, and I appreciate y'all hearing the bill.
So basically what this bill does, it just says that this annual membership and the concierge relationship between the doctor and the patient has absolutely nothing to do with insurance. It does not help you meet your copay. It does not deductibles, anything like that. if you don't have to go to the hospital or see a primary care physician a specialist for some reason, you're, you haven't met your deductible or anything. So this does not help you meet that in any form or fashion. It's just a membership to a particular doctor who, in most cases, is trying to reduce their caseload. Instead of seeing anybody and everybody who wants to come in, they'll limit their practice to 600 or 700 patients, whatever they decide is a good number for them to work on. And it's just not, it has nothing at all to do with insurance.
That is right, Mr. Chairman, and I appreciate that.
Okay, 18.
Thank you, Mr. Chairman. I think you answered the question, Senator. Appreciate you being here, but that was my question. Why do we need the bill? Because I know it can be done now. So we're legitimizing the practice that's going on, but what, are we giving any more protection to the doctors or the people that sign up for this program other than they would for a gym membership or anything else?
We're clarifying and legitimizing the practice. You know, only the high end are doing this right now, and that's why the name concierge medicine. What this, I believe, will do by putting it in our code will expand the use of it. There was an insurance friend that I've met recently named Russ Childers. I was hoping he could be here today, but he's testified in all the other ones. Insurance salesmen could sell a product like this as well to a large group. My point is you know, this is just another tool in the toolkit, but most importantly, it's only being used by people that are savvy enough to have thought of it. But I think by putting it in our code, more people will have access to it and begin to use it, which I think will be good for our constituents.
16.
Thank you, Mr. Chairman. Thank you to the author of the bill. I'm over here.
Yeah.
I have two concerns. First, it seems like that if I were going to do this, I would only put healthy people in my group, young and healthy folk in my group, to minimize my activity that I would have to do. And then secondly, if we're going to put this in the code, it concerns me that there is no place for dispute resolution. And I was with you until you said gym membership, and then I had all these ugly things go around in my head about what happens to people when the gym memberships go bad. So where are we going to send these people? If we're saying that we're authorizing this in the state of Georgia, we're legitimizing it, where is the dispute resolution? Where do they go?
Consumer protection. That'd be the best place for it, because it wouldn't be the standard mechanism for wherever you would in typical healthcare relationships.
So is the consumer going to know that, or will that be in their agreements somewhere?
Yeah, so
how disputes are.
So if you look at line 30, to be considered a direct primary care agreement for the purposes of this code section, such agreement shall be in writing, be signed, and all this list of things.
But it doesn't say anything about dispute resolutions, or did I miss it?
I would just assume it would happen in the standard practice of how other dispute resolutions are dealt with in our regular economy.
Thank you.
15.
Thank you, Mr. Chairman. This is good stuff, Chairman Hill. I appreciate it. The only thing I was trying to understand is when you've got some information down here discussing the physician's ability to, I guess, not accept a patient, or is there any reason why that's codified in there as opposed to just being able to turn someone down for any reason whatsoever?
The reason is because of the standard of practice in our country, and it's a good thing that usually doctors have to do this and they have to do that, and that's usually governed by when government's paying, for the bill, or when insurance is paying for the bill. So this is clarifying some more freedoms for doctors that is not typical in medicine, if that makes sense, because they have. But if people wanted to put specifics of what could occur to allow a patient to be out of the contract, that could be something that could be considered too. But we talked about this in subcommittee, and it was basically just doctors have a higher level, and this is a higher level of care that they're expected to provide. And so this deals with the fact that this is an arm's length transaction.
Would, as far as arm's length, would you not want it further? I mean, to go a little bit further, or maybe not quite as far, and remove any reasons, in that particular section where you might be able to terminate or not accept a patient. I don't want to micromanage this too much. I like the bill.
Oh, you're saying there's too much?
I'm just saying, yeah. I mean, is there any reason why we wouldn't say if a physician's unhappy, or most contracts you can.
We were trying to find a balance there where, but I mean, I appreciate your point.
Yes, sir. Thank you.
Thank you.
I think what in this particular case, this has been going on for at least 10 years here in Georgia. It's in most of your metropolitan areas now. And I guess the sole purpose of this bill is just to clarify that these concierge contracts are not insurance, have nothing to do with insurance. They're a membership to that particular physician.
Yes, sir. I'm for it. I'm just saying that I guess in my estimation, we wouldn't want to all of a sudden reintroduce government regulation into
Right.
what is kind of a private contract.
Mhm.
Yes, sir. Thank you.
Okay. All right, people, it's 9 o'clock and I'm late for rules. Okay, 24.
Thank you, Mr. Chairman. I'll be brief. This is a good bill, and though we've seen it, I will tell you, it's been around. If you want to go back in history, your old Blue Cross contracts were similar. It didn't have anything but primary care. We used to call them family practitioners. This is a good bill. If they don't like each other, you can get out and give 30-day notice. Thank you for bringing this bill.
Thank you, Madam Chair.
25.
Make a motion, do pass.
Okay, now, who's number 11? Do you want to talk? You got 30 seconds.
All right. To Representative Blackman's question, I think on line 35, it says anybody can get out of the contract on either side. And I was also going to call the question, so.
Okay. All right, the question been called and second. All in favor say aye. Aye. All opposed, like sign. Thank y'all. We'll see
Thank
you in
you,
rules.
Mr. Chairman. Appreciate it.
We're gonna have another meeting Wednesday?
No, it's not